pharmacist. I'm an infectious disease physician. But the decisions about these issues have to be made by every medical professional when the system or when the time arises. So in my prior experience, somewhat of an analogy, but not complete, was the HIV epidemic. And I've been doing infectious diseases now for about 40 years, and I was taking care of patients in the early 80s at this hospital, actually 83 started here, when we had no therapy for people with HIV. And at that time, until 84, 85, there really was, among the general public, not a clear understanding of the mechanism of transmission, which is really very specific, as you know, sexual injected drug use or mother to child through breastfeeding. So it really, other than those mechanisms, casual transmission, casual contact would not in any way be a problem. Yet, there was a lot of anxiety, and so the way we handled it in the early days of this hospital when it was still opening, we had a floor, 15 South, which was filled with people with HIV, all of whom were going to die at some point. The death rate was 100%. There were a small percentage of people with certain genetic protections, about 1 or 2%. But at that time, we had virtually no therapy. And all of the nurses were volunteers. The physicians were not. The physicians were people who had to attend to the problem. Obviously, infectious diseases, but also pulmonary, hematology, and others. So for them, there was no choice, and in fact, there was no problem. Surgeons, understandably, were concerned because puncture wounds could transmit. So there were some problems in that area. Okay, so I bring this up as an example of something that happened before, which the medical field was able to understand and properly contain. Now, Ebola is very different in several ways, but in some ways similar. First of all, there's this massive but very localized, presently, as you know, in 3 countries only, a massive epidemic with very few patients outside of that area becoming infected. And in the United States, there have been 3 people who have been infected. 1 came here infected, 2 got transmission from that patient, and 3 others were flown here for special treatment. Now, specifically then, what is the duty to treat? The duty to treat, I think, among physicians is if you have a calling in that area, you must treat with the appropriate precautions, which we now have in a way which would allow for very, very Is that not working?
I'll get him to bring you. I'll get him to bring one down. Here, take this.
Okay. With a very, very small chance of transmission. Now, what about nurses or other people who come in contact? Nurses probably being the individuals who would have the most contact, and ideally, I believe it would be on a voluntary basis. But the practicality of that is such that it probably won't work because the necessity for limited shifts and so on. So I think nurses who, at our hospital, most hospitals, it's going to be intensive care unit nurses, do in fact have a duty to treat because they have expertise in that area. And I don't think if every individual makes a choice, the system will break down. So I believe we all have a duty to treat patients, even if there is a risk of the individual becoming infected. The part which counters the concern is with the proper gowning, which we now understand. It wasn't understood properly as recently as a month or so ago in Texas, but it is now. And this is evolution of knowledge, by the way, and some of the undue criticism of the CDC and so on is totally unwarranted, because we learn quickly as things. We have to accept that all knowledge doesn't come at zero time. Obviously, there's no such thing as that. So we have to be a little bit careful of the undue criticism, in my mind, of what's going on. So I would just summarize by saying that the duty to treat is all of us that have an ability to do so. We also have to have an ability to calm the public. Worse than the virus itself in the United States, is the fear and lack of understanding. And it can't be avoided because it's on the news. Even the New York Times, which is my Bible, has a paper on every day in the front page. Usually well written, but nevertheless, it's there. It can't be avoided. So I think we have to understand that. And those of us who are in the medical field also have a duty to calm the public as much as possible, to understand what, now we're totally off here.
Okay. Okay, thank you. Thank you. Thanks. And now, does this work? It does work now. From the nursing profession, Robyn McKeefrey, who's also with risk management here at the hospital and has a long history of how many years? I won't even ask. Okay. But the perspective of someone with training and experience in nursing.
Good afternoon. Can you hear me? Okay. So I might take a little bit different approach to this, because you're going into medicine. You're not nurses. You're not being trained to be nurses. So let me just start out by saying, from a nursing perspective, the American Nurses Association defines nursing as the protection, the promotion, and the optimization of health and abilities, the prevention of illness and injury, alleviation of suffering, and advocacy in the care of individuals, as well as families, as well as communities, as well as populations. A nurse is a person who cares for the sick or infirmed, is specifically licensed as a healthcare professional, is educated, trained, and skilled in promotion of maintaining health. Do nurses have an ethical duty to treat? So let's start professionally. Significant dollars and resources are expended on behalf of molding nurses to be who they are professionally. So there exists a duty to treat from a professional standpoint. Nurses also are said to have a calling to go into the field of nursing. Therefore, a duty to treat exists on a sheer basis of beneficence. Justice also plays a part. Nurses cannot abandon their patients. Throughout history, we have treated magnitudes of patients, various infectious diseases, bubonic plague, tuberculosis, cholera, HIV, just to mention a few. Why would then Ebola be any different? Nurses have duties too: protect and treat our patients, protect ourselves, protect our families, and protect our communities. In times of epidemics, there are varying degrees of risk, varying degrees of patient outcomes, varying degrees of treatment options. So this leads into some questions and dilemmas in times of epidemics. Ebola is high risk with very low treatment options, sometimes coming down to only supportive care. But then does this lower our duty to treat? And these are some suggestions for you to take back to your small groups. How does the risk for our healthcare workers, for our nurses, compare to the benefit ratio of treating our patients? How can we calculate that risk to be fair, to be equitable, to be ethical? Is it considered malpractice for nurses to refuse to care for a patient with possible or definite Ebola? Is this then considered patient abandonment? Nurses are essential members of our medical team. How do we protect them? What can we do for them? How can we reassure them? We keep them informed of our hospital plans. We provide them with updates regarding what we have received from our authoritative agencies. We provide education on best practice. We provide adequate resources, available equipment, enough space for them to perform their job adequately. We provide hands-on, repetitive training, which requires the demonstration and competency for donning and doffing our PPE, for specimen handling, for waste management, for screening procedures, for isolation protocols, for disinfection techniques. We institute a buddy system with continuous observation. We reduce the number of hours working in the hot rooms to avoid fatigue, to lessen the chance of making a mistake. We provide an ability to communicate with individuals outside of the hot rooms. We have emotional and support resources available for our nurses. It's very tough to work with these patients. We need to support them. We have sign and symptom monitoring after they care for these type of patients. So when we do have a duty to treat, how do we provide the services as nurses? Back in the 80s, we called for volunteers. Do we do that yet again? Should caring for Ebola patients be part of your routine nursing responsibilities? Or should we just implement highly trained individuals, ICU nurses, nurses who have specific training in infection control? Should nurses be compensated financially for caring for Ebola patients? Should they be compensated in different ways, like for time off? From a risk management perspective, let me just please define for you what risk management really is. It is the identification, the assessment, and prioritization of risks, followed by a coordinated and economical application of resources in order to minimize, to monitor, to control the probability and impact of unfortunate events or to maximize the realization of opportunities. So does risk management. What are our responsibilities? What are our duties here? We need to protect patients. It is our primary goal. We need to protect our staff, to protect the hospital, also to protect our communities, to protect our families. Making the same suggestions that we have to promote and optimize the care and treatment of our patients, to stay informed, to ask questions, and to stay safe. We have a duty to treat, nursing and risk management.
Thank you, Robyn. Not too loud. Is it? Okay, no questions later. Okay. So next, representing another profession, we have Cornelius Dery from Ghana, who is a Catholic priest, who is active professionally at St. Catherine's Hospital in Smithtown in clinical pastoral care, and who I have discovered over the last 4 or 5 months is an extraordinarily thoughtful individual who has a perspective of relevance because indeed in West Africa there are a number of chaplains who have died in the Ebola epidemic. So to speak from that professional perspective, and then also, as we were discussing yesterday evening, make a few comments about some of the behavioral dimensions of this epidemic in West Africa. Stand up, show whatever you like.
Good afternoon, my dear friends. In times of pandemics like the yellow fever and SARS and, of course, Ebola, the natural response is fear and panic, which in most cases worsen the situation and cause the virus to spread. And for those of us who work in the medical setting, we are caught in a dilemma. I know you are training to be medical doctors, but definitely you will work in collaboration with chaplains. I believe some of you or most of you have seen the chaplains we have around here. The work of the chaplain is to collaborate with the other medical staff. The hospital chaplain's duty is to offer ministry, religious and spiritual guidance to patients, their family members, and other caregivers. They counsel patients undergoing surgical procedures and facing end-of-life issues. They also offer comfort and support to patients' family and calm angry and emotionally distraught friends and family members. Since a high number of people who contract the Ebola virus in the affected areas die, anyone who gets infected thinks of death and end-of-life issues. And as you know, the emotions arise as people near death or face life-threatening situations. So people have intense emotions and pains and feeling of dissolution, meaninglessness, discord, anger, fear, regret, guilt, denial, helplessness, anxiety, and the like. And especially in the case of Ebola patients, because they are quarantined or isolated, they may also have feelings of loneliness, abandonment, and neglect, and lack of love, and loss of freedom. Now, tough spiritual questions flood the minds of such people. Was I a good person? Should I fight death or let it come naturally? And sometimes some blame themselves. Why did I go to the aid of that patient? I believe the nurse in Texas probably had these thoughts going through her mind. And Eric Duncan, who died, we are told he helped a pregnant woman. I believe when he was nearing the end of his life, probably he was blaming himself. Why did I even go to the aid of that person? So the chaplain's duty is to come to the aid of these people. So usually we say that the chaplain is somebody who looks for a holistic healing of the person. So he looks for physical healing, emotional healing, spiritual healing, and sometimes to help the person to have the strength to face death peacefully. And sometimes to help people to have a good death. And as a Catholic priest, the understanding of a good death is to help the person to make a good confession, receive the sacrament of the sick, and prepare himself to meet God. Now, most Africans believe in the concept of cause and effect. In other words, for most Africans who are suffering from sickness or any other suffering, they always question why this thing is happening. The first answer is, this is spiritual. Somebody cast a spell on me. Somebody has bewitched me. Somebody has consulted the juju man to do something to me. And so sometimes we notice that some of these ideas that go through the person's mind affect his response to treatment. And you will see that in most of the Ebola cases, especially in West Africa, you will see people exhibiting some of these superstitions and some of these thoughts. So we are told that many Ebola patients see their situation as a curse rather than a medical illness. Some have magical thinking. They think somebody, an enemy, somebody who is trying to eliminate them, has caused that. And sometimes it's not only maybe the illiterate, but even some pastors go to the extent to collaborate that. In my own country, Ghana, where there is one Pentecostal pastor who preached one Sunday that Ebola is a demonic spiritual plague, and that it has earmarked Ghana as its next stop. So people who hear pastors like this, when they are infected with Ebola, will believe that this is just one of the spiritual things. So some of them do not seek to have treatment. They just feel that it has come. It has to come, and I've been affected, so I just live with it and die with it. Now, you will see that we also have some cultural practices that have also pushed this Ebola thing in West Africa, especially to go to spread. We talk about the eating of bushmeat, which is a delicacy for most West Africans, as some of you have heard. And now this has been banned in most countries. We also have the situation of handshake and hugging, which is common in Africa. You have to touch the person so that the person will know that you appreciate his humanness. And in Ghana, where I come from and returned in September, we no longer shake hands. We do the bump greeting or the waving, even in church. There is also the communitarian life that we live, whereby people feel that they have a duty to treat their family members who are sick. So when somebody is sick, you can't just abandon the person. You have to stay with the person, help the person. And especially in some cultures like mine, it's not good for somebody to die without anybody holding the person. So most people want to stand by the person and hold the person and see the person die. And most Africans believe that death is a journey. And so when somebody is dying, they have to give the person water to drink before the person dies. So all these practices put the person in proximity to the patient and they catch the disease. We also have the practice of washing and dressing patients and sitting by them for long hours before they are buried. And so in situations where people are buried without being washed, the families take offense to that. Now, the call to duty, compulsory or optional. There are examples of religious people who believe that to help treat an Ebola patient is compulsory for them. So some chaplains feel the need to help such patients, and they take the example from Jesus Christ. They tell us, Jesus never abandoned the sick, and they use the examples of Jesus touching the lepers and Jesus, the woman with hemorrhages touching Jesus. So we have some missionaries like, as we have heard, Nancy Wright-Ball and other people who belong to the evangelical missionaries who went to Liberia to help. And when they were infested and they came home, they are cured, and some of them want to go back. They feel that it is a call. They can't leave it. And we have the 2 Spanish priests who died in caring for Ebola patients. We have the situation of the pastors in the cases of those patients who caught the disease in Texas. The Pastor George Mason, who cared for Thomas Duncan and his fiancée and their family and all that. And then we have the situation of the pastor of the nurse Nancy Pham, who also cared for them. So we see that there is a situation where some people feel that caring for the patient is a call, is something that they cannot abandon, because Jesus, from whom we take our example, will never abandon them. But we also have some people who feel that it is not so compulsory. We have the example of the son of the Liberian president who is practicing medicine in Georgia, who feels that he doesn't have to go back and help his people. So the question comes, why is it that some people who are not from Liberia are ready to go and risk their lives, and some others who are from there feel that they don't have to go? So in my view, I think that in times of deadly epidemics like Ebola, what we are to do for the sake of the patients is something that we leave to the consciences of individuals, people who feel they have the strength and the courage to face such situations. We also see that in such situations, we have to celebrate other people who take the challenge and go out of their comfort zones to help people who have Ebola. And when such people are coming back, we have to celebrate them. And that's why, personally, I feel that the compulsory quarantine should not be encouraged, and also we should only encourage self-monitoring and immediate report to the medical facilities. Love with caution. Love with precaution. Chaplains would need to follow the advice and direction of medical experts. Jesus told us, be wise as serpents and harmless as doves. It won't be wise to sacrifice one's life for one patient when there is a higher good which will be achieved by taking care of many other patients in the future. Thank you very much.
You don't have to start doing this. Thank you very much, Cornelius. That was wonderful. Dr. Andrew Wackett. Everybody knows Dr. Wackett. Please.
Thank you. I guess I can give the viewpoint from the ER. I think some of these questions that are asked are very straightforward. Some of them become slightly gray when you come to working in this setting. First of all, the question being asked: do the ER physicians have a duty to treat these patients? It's an easy question to answer, and the answer to that is yes, of course. We've gone into this field realizing that there is some risk in what we do. We take care of patients that are violent. We take care of patients that bring disease that we could potentially catch. And this is stuff that we are, that we are knowledgeable about going into this. So when these issues came up, there was never any question amongst our staff that we would be taking care of these patients. Having said that, though, we want to do it in a safe manner. We have precedents as far as like hazmat experiences are concerned. If patients come in through the emergency department and they are contaminated by something that could potentially harm us, we are not expected to start treating that patient until we make them safe for us to handle. So I have to give the hospital credit. I think they have really stepped up and gone above and beyond what they needed to for this situation to make us all safe and to feel quite safe with handling these patients. As far as the nursing staff is concerned in the ED, once again, another easy question to answer. There was never any question that the nurses would be part of this treatment. We work together as a very close-knit team in the emergency department, and we definitely rely on both physicians and nurses to treat patients. So again, there was never any issues there. It becomes a little bit more complicated when you start to think about the other ancillary staff in the emergency department. We have patient care techs, we have x-ray techs, we have respiratory therapists, we have lots of students from first and second year ICM students to third year clerks, fourth year sub-Is, we have residents as well. And we thought the safest plan for these, for folks that are less experienced, we thought that this wasn't the sort of cases that would be best to learn upon, at least inside the hot zone, but rather they could learn on these cases in the cold zone. It also becomes quite complicated when you deal with EMS systems. These are folks, many of which have volunteered, and their level of training is quite variable. So in those situations, when we have knowledge about these cases, we've decided that there would be a Stony Brook team that was trained that would go out to retrieve these patients and then bring them to this hospital so that it could be done most safely. What I fear is the panic that's been brought up before. The ER is the receiver of this panic oftentimes, and although I'm not so concerned about Ebola, I'm quite concerned about the thousands of patients that will come in with flu-type symptoms thinking that they have Ebola. That does several things. It crowds the emergency department and makes it more difficult to take care of patients that are truly ill. And it also takes very critical staff out of their typical roles. When we actually truly have to take care of a patient with Ebola, it really requires one physician and one nurse that's going to step out of their typical role of taking care of everyone else in their zone of the emergency department. And if that becomes abused, it's going to become very difficult to handle all of those other cases. So that's what I worry about. But as far as the duty to treat is concerned, it's an easy answer.
Thank you.
Hi. As most of you probably know, I'm the director of the Pediatric Intensive Care Unit. And like my colleagues before me, there is no question about the duty to treat. But I think when you're dealing with pediatrics, it ups the ante a little bit because not only do you have a child, but you also have a parent. We have, in the planning for how are we going to deal with Ebola, we have a similar plan to the emergency department, one doctor, one nurse. And as has already been alluded to in this institution, once any patient with Ebola leaves the emergency department, they will go to one isolated room in the hospital, and they will be cared for by intensive care unit staff. The adults will be cared for by the medical intensive care unit, docs and nurses. The children will be cared for by the pediatric intensive care unit, docs and nurses. They may not be critically ill, but they'll be cared for by the ICU staff because they could become critically ill. And this is a way to minimize the exposure of hospital staff in terms of numbers of staff potentially exposed to the patient. But we've had the question, okay, we have a child admitted now with Ebola or suspected Ebola. What do we do with the parent? Most children who are admitted, their parents will not leave them. They don't want to leave them. If the child is sick and the parent isn't, in terms of preventing Ebola in the parent, logic would say separate them and don't let the parent be with the sick child. In reality, it will be very difficult to separate a parent from a sick child. So then do you put the parent in a hazmat suit? And how long can you wear a hazmat suit before you sweat to death? I think the plan for the doctors and nurses is shifts of 2 to 6 hours. I've heard different periods of time. Then you've got to take that thing off because it's very hot and it's very uncomfortable. So we have the additional... Okay, so 2 to 4 hours.
Two while you're doing patient care.
Okay, so you're going to tell a parent, okay, you can stay with your child for 2 hours. Now you have to get out of the suit and leave the room for how long? And that won't work real well for the parent, and it won't work real well for the child, depending on the age of the child. So there are a lot of sort of practical issues that we're going to have to deal with if we ever, knock wood, we will never have to deal with this, but that come up in the context of pediatrics. As an institution, we also have a duty to treat, but we also have a duty to protect ourselves and our staff. And so many of the discussions have occurred around what level do we have to treat? We can't treat with the same level of care that we treat everybody else. Because, for example, if we have an Ebola patient, we will have little handheld lab test, point-of-care testing devices that will do a limited number of tests. We can't send blood to the lab. If a tube of blood from a patient with Ebola drops in the lab, the entire lab will close down until they can decontaminate it. So we will not have access to a lot of the lab tests we normally would have. It's a hemorrhagic disease. We will not be able to do coagulation tests, platelet counts, and so forth. So do we need to train the hematologists to take care of these patients if we're not going to have the relevant lab tests? And what do we do if a patient requires surgery? We're not going to roll them down the hall into the operating room and potentially risk exposing a lot of other people. So I think there are a lot of, yes, we have a duty to treat, but there are a lot of caveats to that, and that probably is a good lead-in to you.
Could you say one thing?
Oh, yeah, I forgot to say. And in the context, as I said, we have only intensive care docs and nurses taking care of these patients in order to minimize the number of people who will be potentially exposed. Medical students and residents will not be allowed to provide direct patient care to patients with Ebola or suspected Ebola. You all have to be supervised. You are all trainees. And you have to be supervised by somebody like me or Dr. Steigbigel or Dr. Wackett. So if we have to be there anyway, There is no justification for you risking an exposure. So you will not be allowed to take direct care of these patients.
Thank you very much. That's great. One remembers that Walker Percy was a medical student when he contracted tuberculosis, and it made him into a great novelist.
Hi, everyone. I am Michael Roess. I'm a philosopher here. And I'm going to be echoing a lot of what you've heard today. There is a limited duty to treat, but I'm going to try to give you some tools for thinking about how to treat future epidemics. So I'm going to begin by mentioning the ground of the duty to treat, talking a little bit more about what limits those duties to treat when it is limited, and then discussing the details of the current Ebola situation, I'll call it. So we've heard about the social contract and about the duty to beneficence, and I won't go into that. But there is also a duty grounded in the special capabilities that healthcare workers develop in their training and in their practice. They are able to care for people who are diseased and limit their own risks in caring for people with disease in ways that other people cannot. And sometimes having these special capabilities increases your duty to do various things. In times of outbreak, this is especially true. It may be the case that if there is a flood of people coming to the ER, perhaps with Ebola, perhaps without, you may need to forego a vacation or work a couple of extra shifts just to make sure everything works fine. Moving on to the limits in the duty to care, there are three that I would really like to focus on. One is your ability to do any good. If there is no good that can be done and there's a great risk of contracting a lethal disease, then there isn't really any duty to treat. Of course, there is always palliation, so there's always some good that you can do, but the good that can be done must be balanced against the risk. I'd also like to note that it's not only the availability of treatments that lead to the good that can be done, also the adequacy of facilities. One of the big differences between Ebola in the United States right now and Ebola in West Africa is that we do have adequate facilities to treat this that don't exist over there. And also your own adequacy in terms of training. If you are an intensivist or an ER doc, you are probably going to be better equipped to treat someone with Ebola than a dermatologist. So some people have more duty than others. Second, the severity of the disease is a major factor in the extent to your risk. If it is an extremely severe disease, then you may not have a duty. Your duty might be limited. As we've heard before, AIDS is a really good case to compare the current Ebola to, because AIDS was, in the late 80s, 100% lethal. However, it wasn't very transmissible, so the limitations related to the severity of the disease are not universal. You also are required to, if it's going to be limited, have a very contagious disease. And if another case to compare the contagion of the disease might be influenza, influenza is a serious disease, and we don't expect doctors to abandon their posts every year that it comes around, even though thousands of people die every year. So you really need to have a severely limited duty to treat a highly contagious and highly lethal disease. With that in mind, let's look at Ebola right now. How contagious is it? We know that it's spread across West Africa. We also know that they have suboptimal treating conditions. Here we've had 8 patients treated from the beginning to the end of the disease, and it has only spread to 2 people. In that case, it was a product of a healthcare facility that wasn't adequately prepared to deal with the disease at the time. So it looks as though it is not terribly contagious here. There are risks, but those risks can be managed with ample facilities. How lethal is it? Again, there's a big question on this. We have reports of a 70% mortality rate in West Africa. Of the 8 people who have been treated in the United States, 7 of them have survived. That's an 88% survival rate. And the one person who didn't, he was turned away on September 25th and wasn't treated until September 28th, 3 days later, when his symptoms were much worse. So we have good cause to think that treatment will do a great deal of good here. So the risk to the healthcare worker can be managed, and the good to the patient seems to be very strong. We can make we can reduce a survival rate from 30%. We can raise the survival rate from 30% to 88% or so. We don't know exactly. For this reason, it seems as though we have a limited duty to treat Ebola right now. This duty falls more strongly on those with the relevant expertise. It does not fall on people who aren't well trained, so nurses straight out of nursing school, and medical students and residents don't have a duty to treat because they very well could cause more harm than good. They might themselves get the disease and be another case that needs to be treated, and we do have scarce resources here.
Quick advertisement. Michael Roess, product of the Stony Brook Philosophy Department, is a real asset to all of our work. Now, before we go to Dr. Chandran, I'm going to ask Dr. Carla Kearns for 2 minutes to talk a little bit about the dialysis, the CPR, and the intubation, because that's been in the news a lot, and it has to do with ethical issues.
So I've been at the National Bioethics meeting where there was a standing room only, incredibly contentious debate about CPR in folks with Ebola. So do you think we should do CPR in these patients?
Show of hands.
So
yes.
So would it make...
Sure.
Yeah, so we've got a few. Would it make a difference if I said that the majority of patients who have Ebola, who reach a point of having their heart stop, are going to be in multi-organ system failure and die anyway? Anybody want to do CPR now? Okay, so we have some. The other issue that comes up, though, is what if they have something else that's reversible? What if they develop appendicitis? What if they get something that we should otherwise be able to treat? That's the hard case. The situation of something that isn't going to help and is high risk to the provider, there's pretty clear consensus we shouldn't do. Dialysis, though, has been very contentious because what happens to these folks is a few days in, they develop diarrhea, nausea, vomiting. They can lose liters and liters and liters of fluid a day, and that's how they die, by and large. They get dehydrated, hypotensive, go into multi-organ failure. And sometimes dialysis can make a difference in those patients. On the other hand, dialysis takes 300 cc's of blood out of your body every minute and runs it through a machine. Some of that gets aerosolized. There's a high risk to the person who's doing it. And so the CDC has just put out new guidelines about how to do dialysis as safely as possible in these patients. And it's this kind of risk to staff versus benefit to patient balancing test that they've used at NIH, Emory, and Nebraska in taking care of patients. We have a responsibility to the patient in front of us. We have a responsibility to our other patients. We have a responsibility not to become patients ourselves. And then we have a responsibility to make sure that the community is protected from infectious disease. Leave it at that.
Very helpful. Dr. Kearns, that was great. If you have an opportunity, email us those recent statements from the CDC, and we'll circulate them. Now, Dr. Latha Chandran, you have a terrible challenge here, which is to bring all this together. You can, of course, as a pediatrician, speak from your own voice, but also give us some wisdom based on what you've heard.
I'm not sure if I can do that, but I'll try. I was sitting here. In a way, it's good to be the last person because you've heard everybody else's thoughts and have time to sort of think about how to wrap this up and how to think about this. As a general pediatrician, do I have a duty to treat? I was sitting here thinking about that. Yes, I've been in practice. I have a contract. The country has invested in my education. I have special skill to take care of little children. Therefore, I feel I have a duty to treat. Now, what happens when a patient is in the outpatient? A lot of this protocols has been about inpatient protocols. So in the outpatient, we have the same situation. A kid could be walking in with a parent and have a fever, and then we may find out, oh, my God, this child was traveling out of the country. What do we do? And again, these protocols have evolved over time as we have more experience with more patients. And in fact, the Bellevue people were telling me their protocol changed at least 5 times. and now they're happy with their protocol. So I was discussing with them as well. We have a protocol in our school right now where when the patient calls for an appointment for illness, which is very, very common, as you know, fever and diarrhea and vomiting are very common pediatric illnesses. So there's a lot of phone calls coming in for appointments. They now have triage protocol. So the first question they ask is about, have you traveled to any of these 4 countries? And if the answer is yes, even if they don't have any symptoms, they are not asked not to come to the clinic, but rather if they do have symptoms, which there is, again, a list of maybe 12 symptoms, starting with fever, vomiting, any hemorrhaging, myalgias, which, if you think about the common cold or the flu, it's likely that somebody has one of those symptoms. It's very common. Then if they are sick, they are asked to go to the ER through that protocol if they feel they're sick. It's possible that somebody may show up to the clinic. What do we do then? We have sent the protocol out to all the clinic personnel, and they are supposed to ask the same questions. And what if we find out that somebody is at risk for Ebola? The current protocol is to put them in a room, an isolation room. And again, stay 3 feet away from the potential risk patient. As Margaret Parker said, in pediatrics, that's a pretty tough thing to do. So at this point, we are not going to follow the 3 feet protocol because it's not possible. The rooms are not big enough to do that. And we will still isolate them, keep the parent in the room, like you said, and have the minimum number of staff go in and take care of the patient, of course, using the personal protective equipment. As far as some of the other things that I was thinking about, the dialysis that you were talking about, when HIV came around, people were very scared of their own mortality. And then we realized that the transmission is not as high as, let's say, hepatitis. The viral load in a cc of blood is much greater for hepatitis B. The problem with Ebola is that the viral load is in the billions, and therefore it is highly, highly infectious. And that's why we have to balance the risk to the person and the benefit to the patient in that equation. And I was sitting here also thinking, do medical students have a duty to treat? And I probably want to ask the philosopher that question because I really don't know if they have a duty to treat.
Oh, I don't think so. I think they have, if anything, a duty not to treat.
No, not just for Ebola. Do they have a duty to treat?
They have a duty to learn how to treat.
Yes. Yeah, that's what I thought because, I think they have a duty to learn how to treat, but I don't think because they're not licensed, they're not physicians yet, I don't think they have a duty to treat in a disease, except for an emergency where they know how to do CPR or something like that. The other comment I wanted to make was about the vaccine that's now gone through phase 1 trials. I think this is going to be relatively quickly moved on to phase 3 trials in Africa, and I think that's really very hopeful because fortunately for us, this viral genome is not very complicated. And the rate at which the vaccine has been developed is pretty impressive. And therefore, I think the vaccine will become available and it will become helpful for all of us to get vaccinated. People talk about, there was some commentary on the radio about, 80,000 people die a year from influenza. And people don't panic about it. People don't get the vaccines about it. But the risk for the doctors is we all have to get vaccinated against influenza. So there is no real risk for the doctors or the care providers in getting that. But since Ebola doesn't have a vaccine, the risk is real. So I think that, among the people that talked about here, clearly if you sign up to be an ER doc, then there is a duty to treat. If you sign up to be an intensivist, you have a duty to treat. Infectious disease doctors, again, you have a duty to treat. The other folks, primary care people, if you are in a situation where the patient is there, you have a duty to treat, is the way I would see it. Minimizing the exposure is important. One other thing I wanted to mention is that we have a gowning training for our students. All of you have had that training, right? How to wear, not yet. Coming up soon. Okay, so what we are going to do is, so far, our emphasis was on how do you wear a gown in a sterile way so that you don't infect the sterile field when you go in for surgery. But now we're also going to think about how do you remove your gown in a way that you're not exposed to any of those things. So I've spoken with Peggy Seidman. We're going to add that doffing the gown as part of that. Not because you have to take care of Ebola, but in your lifetime there may be another viral infection that comes along, and you may need to know how to do that. So that's sort of our plan.
Wow. I would say plenty of wisdom from everybody, and thank you. So we now have some time. Instead of just rushing off to small groups, this is such a valuable resource here. Don't get long-winded, but ask direct questions. You can focus on any one individual or on several. But let's just open it up to a community dialogue. Yes, sir.
So this is
Speak up real loud.
For Dr. Chandran. You said that medical students specifically have a duty to learn how to treat, and that they do not have their license and don't have the training. How would you then approach the residents, specifically senior residents, and do they have the duty to treat?
Senior residents are licensed physicians, and therefore they have a duty to treat. However, in the case of Ebola, we want to minimize that risk, and that's why we are limiting the number of people who are exposed to the illness. But as a general duty to treat, absolutely yes.
Would anyone else?
There are rules and regulations made, and in this epidemic, the number of people making these rules and regulations who've had experience with Ebola is probably 0.0001%. But there are, in fact, people who have treated patients. And there has this residents shall not treat patients. Well, it was a very interesting email from a physician who has, in fact, treated patients with Ebola. He's been there. He's done it. And he states that the suggestion that residents not be involved is 100% incorrect. And why does he say that? Because he states that the residents are as good as anybody else on putting on and taking off the gowns. And that is really the crucial part, your manual dexterity to put things on and taking them off. That's what's critical in this event. So I bring this up. It's a little controversial, but that's been part of my life, so I don't have any problem with that. We have to also listen to those who've really been there and not just those who are making rules who have not.
Excellent point. I think that's a good philosophy of life, actually. Okay, someone else. Yes, ma'am.
I guess that what I'm most worried about with the Ebola epidemic is the precedent that it sets in the medical community. So I guess this is a question for Dr. Wackett, who probably has the most vulnerable to the situation. So in light of Dr. Craig Spencer's complete itinerary, sexual behaviors, his exact ride on the subway, how can we protect our rights as a medical community so that that doesn't happen in the future to our children or having our addresses publicized?
Yeah, that's interesting. I thought about that same thing. I mean, if that surely seemed to be a HIPAA violation to me, all the information, I was amazed at how people's names would go out and all that. And I'm honestly not sure how they get away with that if things change in a public health format. But I think that is something that's important. I mean, as a healthcare worker, that's information that we would hopefully certainly not share with anyone else. Those are our private matters. As far as the vulnerability of myself is concerned, as far as the safety of it, I feel quite safe, but I feel that way because of what the hospital's done about it. I would certainly not run into a room to perform CPR on a patient if I didn't have the proper outfit on. I think the likelihood of me doing anything good for them is almost zero, and the likelihood of me getting it would be much, much higher than that. So that's how I sort of view that.
Do you think there's any policy changes that could be made to protect our rights while fulfilling our duty to treat anyone disagreeing?
To protect the rights of the patient, are you speaking about?
As a medical,
as a doctor saying that they couldn't give your name out, that you had spoken to us. I don't know a lot about that, honestly. I'd have to pass that off to someone else. I mean, I know a lot about what the rights of the patient are, but I'm not exactly sure how that translates to the healthcare worker. I guess at some point you switch from being a healthcare worker to a patient if you were either contracted the virus or you were even exposed and had to be quarantined for it. So I think those same rights would cross over, but I'm not absolutely certain.
This gentleman in the green shirt, please. Well, that's you. A T-shirt with green on the front.
I think this might be more for Dr. Wackett, but anyone. I just am curious about how and who is involved in the process of, like, for instance, Stony Brook Hospital being able to volunteer to take care of patients with Ebola.
I'm not volunteering. I'm mandated to, but I'm happy to do it. As far as what?
How the hospital become a facility that takes care of patients?
Oh, I see what you're saying.
How the hospital volunteers?
So that's a very good question. We are a state institution, and we are the only university hospital in this county. So, as a state institution that gets state funding, we have an obligation to the state's people. And a decision was made at the highest levels, including the dean, the CEO, and the COO, that do we have the capabilities to enact a protocol and to carry out a protocol. And that's the level at which the decision was made.
Someone else, yes.
Yeah, seems like most people seem to be suggesting that you're confident in this institution's ability to deal with Ebola patients. I'd like to ask specifically more towards the nurses side of things, though, especially with yesterday and today, a lot of nurses in California expressed concern that the California medical system they don't have the resources, they don't feel confident dealing with Ebola patients. So do you think that the general nursing staff here feels confident to deal with Ebola patients? And also with isolation units set up in the ICU for Ebola patients, are you worried how that might affect the other functions of the ICU and other patients that are not affected with Ebola?
So I can tell you over the last couple of weeks, as the hospital has become more informed and various guidelines have come forth. A couple of weeks ago, our nurses were expressing dire concerns that they weren't informed, that they weren't educated, that they were afraid they didn't have the correct equipment, that there wasn't enough room dedicated for them to do their work. And my feeling as to going out on the floors now and speaking to various nurses who have been educated, who have been trained, who have gained competency, they're feeling much better. They're feeling much better about the overall emergency preparedness plan that we have adopted. We have Q&A sessions, town hall meetings. We have administrative rounds where people are afforded the opportunity to ask questions, to stay informed, to remain in the loop, and we encourage that. So I think that we're making progress from a nursing perspective, as well as a hospital perspective and a physician perspective.
Did someone else? Oh, please.
You asked about the effect on the ICU. The room or rooms to which Ebola patients will be taken are not in any of the current ICUs. They're identified rooms that have the available anteroom and space. The ICU will go to them. As far as the preparedness of the staff, the emergency department staff was first in the training. Many or most of them have been trained and are probably quite comfortable. The medical ICU staff are undergoing training now and have a varying degree of comfort. Pediatrics has kind of been left till the end because the assumption is we're going to have adults and not kids. I hope to God we don't have any children with Ebola come soon, because none of us in pediatrics, myself included, are prepared to take care of them. My training is tomorrow. So as time goes on, there will be a larger and larger pool of Physicians, nurses, respiratory therapists are also going to have to be trained, and other members of the healthcare team, because it's not just the doctors and the nurses, but there are other people who are going to have to be involved in various support roles. And so as time goes on and more people are trained, the level of comfort will rise. But right now there's still considerable anxiety.
A couple more questions, one from the middle and then one from over there. Yeah, please, yes.
At what point do we draw a line about with all of our training that we're doing? We're spending a lot of money on training lots of different levels of people. For maybe that might be 5 to 10 people, if at all, in the United States. Are we overdoing it at some point and taking a lot of resources away from somewhere else?
Sure. So there is a significant risk if we aren't trained that the thing spreads, and that's a very, very bad case. So if we have the resources, that seems like a good way to allocate them. If the risk of this disease were less severe, then maybe it would be overkill.
That's an absolutely fantastic question. Because it brings up the whole idea of how many institutions should become involved in this. And let me put it very straight. Bellevue Hospital has been training for this for 5 months. They have ability to take care of 20 patients with anterooms where the laboratories are right next door. So it's an ideal system. So the question arises, and it's a question, whether in fact the current system of having spot places in contrast to transferring patients, if in fact that can be done well, it needs to be raised. And so you're basically asking the question, spreading out the care versus concentrating the care. And I think from the simplistic idea of an infectious disease, you want to concentrate. You have an index, and then you have a spread. You don't want multiple individuals from multiple index cases. So I think your question raises multiple areas of concern and need to be addressed.
Dr. Wackett and then Dr.
I actually trained at 2 hospitals because I work in 2 separate emergency departments here and out east at Peconic Bay Medical Center. So I had the luxury of getting 4 hours of training instead of 2 hours of training. So, what both places did, they did reuse what they could reuse. Obviously you want to use gloves and masks, and obviously you're not going to be keeping them. But the overall outfit, multiple people tried on the same outfit, and I felt safe doing such. So there wasn't a huge waste of money there. Physicians aren't really paid more for spending an extra 4 hours training anyway. It's just what we do. The nurses were compensated. It's a different pay structure, so that's definitely things that had to be thought about. I also agree that I don't think everybody needs to be trained, especially in a smaller hospital out there where the likelihood of them holding onto an Ebola patient for the critical care staff and the surgeons and everyone else to take care of it's just not going to happen. But there is a slight chance that the ER crew could see that patient and then rapidly isolate them and transfer them out. So I think that those efforts have to be catered to those that are most likely to see those sort of patients.
Tech next to that unit at Bellevue, I want him to triple my salary. Because I swore no oath, right?
So if we never get an Ebola patient, is all the training and infection control wasted, or is it useful for other patients we take care of?
I was thinking about that resource question, and it is true that we are spending a lot of resources in this, but it's a training for the future whenever the next epidemic or whatever comes along, MERS and SARS. There are so many. Now medicine is global. So, and with all the zoonotic diseases that we are in close proximity with the animals, it's only a matter of time before another virus comes along. And so these are general principles that we can use for the rest of our careers.
I want to see if our C. diff rate goes down in the next 6 months.
Well, we have excellent infection control issues. Yeah. They're disease specific.
Sure.
There's a science behind it. They're micro-specific, knowing how it's transmitted.
Sure.
So a global transfer from Ebola, which has a certain mechanism of transmission, is not relevant to other diseases. So, no, it is not.
It could be, right? For another disease that could pass away.
We have one more question from the left over here. Not politically, of course, but someone over here had a question. Someone raised a hand. Okay, is there one other question? Yes, okay, Brianna, you're the last one.
So I know a lot of you mentioned that fear is a major problem with this Ebola problem and the problems that it can cause. So as medical students, I know that I've had friends and family ask, like, you know, what should we think? You know, shouldn't we be afraid? So we don't have a lot of time to sit down with them and really explain everything that you're sharing with us today. Like, what do you think the best thing would be to tell them to limit that fear?
Did everybody get that? What do you say to your family members when they're worried about you and you want to keep their minds? Anyone from our panel? That's actually kind of a deanish comment. You too.
I was going to say that, you know, I just read somewhere that Wikipedia is doing a fabulous job of getting all the information and going down to the actual source and putting that. So for the common person, I think, you know, the fear and the panic and the worry about it, if you read Wikipedia, it gives you a fairly good understanding of how this disease is transmitted. And I think that is what I would say to an average person.
Okay. Thank you very much, Dr. Petrano.
Just want to thank our panel for being part of this today, and certainly a great, timely discussion. If I could just have a minute of your time, in case this has all been too heavy, something a little lighter. One of the parts of MCS are little mini courses that we call selectives, and they comprise the last 5 sessions of the course, last 10 hours. And there is a block that is assigned for them after the main part of the course out in the spring. And everybody will take one selective. I'll show you a place online where some of them are listed. But we have a number of them that kind of run not in that individual time block, but are kind of open, and they run kind of free form, involving some of you guys just meeting with the instructors. And I'll be letting you know about some of them that are opening up. One that's opening up right now is Dr. Jack Houlihan, Dr. Marie Basil, and Dr. Richard Bronson have an elective on poetry writing as a course to reflection in medicine, and also as a service to the community. It's something called the Astonished Harvest Project, and that's these 3 doctors, along with some students from here in Stony Brook, go out to the community to share poems and reflections about the experience of illness, the experience of medicine, the experience of doctoring. And so they have up to 6 open places for some of you, if you would like to do that selective with them, that elective. And what it involves is it's once a month for about 5 months. You go to one of their meetings out in the community, and you spend a little time, not necessarily every time, but you get to share some of your own work, do some of your own writing, share some of your own poetry. So if you are literary-minded and would like to do that as an elective, I'm going to send an email out. You can email me back, and if you're interested in that, we'll see if we can't get you a selective position in the Astonished Harvest group. And good enough?
We're all set.
All right.
I just want to do this one more time with Dr.
I want to do that with the dean. I want to do that.